I'd like to have another lecture from Dr. Perros, which is a pre-recorded lecture on autoimmune thyroid diseases. Following this lecture, will be open to panel discussions from all our speakers regarding any questions on these topics. Thank you.
Ladies and gentlemen, once more, I'd like to thank the organizers and Professor Hussain for the invitation. So over the next 20-25 minutes, I'd like to take, first of all, a historical tour into thyroid autoimmunity, then focus more on autoimmunity, the terminology we use, something about the pathogenesis, and then I will share some what I call clinical lessons that I've learned from my own experience. Brief glimpse into the future, and then I'll finish off with some key messages. So I'm going to take you back to 1908, and on that year, the Nobel Prize for Medicine and Physiology was given to Paul Ehrlich, a Prussian scientist who was also known for using the phrase magic bullet. He was responsible for creating an anti-serum for diphtheria and for the first effective treatment for syphilis. And he was interested in immunology, and he anticipated autoimmunity as a possibility, and he called it horror autotoxicus. But Paul Ehrlich's view was that this was a situation that could never really arise in real life, because it was such a terrible thing that would happen for the organism, it would kill it. So horror autotoxicus was not a real disease, in his view. And he was extremely influential, and that view was shared by his peers and by other scientists. Several years later, another scientist in the US, Noel Rose, performed a really interesting and groundbreaking experiment. What he did was that he took thyroid glands from rabbits and he mashed them up and prepared a solution that contained thyroglobulin, and he injected it back to the rabbits. What he found was that the rabbits produced antibodies to thyroglobulin. So for the first time, he showed that in an animal model, autoimmunity actually existed. Now, this was so much against the dogma that prevailed that he had terrible difficulty convincing his peers about his experiments. So he had to repeat them many times, and it took him about 5 years before his findings were eventually published. And he is now considered the father of autoimmunity. Once his findings were published, within a year, immunologists from London, Deborah Doniak and Ivan Reut, showed conclusively that these antibodies actually existed and circulated in patients with Hashimoto's disease. So horror autotoxicus proved to be real, and the journey of studying thyroid and other types of autoimmunity started at that point. So what is autoimmunity? Well, it's a form of self-harm, if you like. Those of you who are interested in football, it's like scoring an own goal. And here is a depiction of autoimmunity. The red cell here could be, for instance, the thyrocyte, and it is being attacked by lymphocytes, shown in the yellow circles. And in addition, we can have antibodies that recognize and bind to specific epitopes on the surface of the cell, and that can mediate all kinds of biological effects. But the terminology is really confusing, and even to endocrinologists. And here are some of the terms that are being used, and some of them overlap, they are synonymous, and it's a real mess. So I've really done away with most of this, and for the rest of this talk, I'm just going to concentrate on the 5 concepts. Now, Hashimoto's disease is a destructive autoimmune disease, and as a result, the patient becomes hypothyroid. Typically, this is a slow process. It takes years to evolve. It is irreversible, and for hypothyroidism to ensue, 90% or more the thyroid gland needs to be destroyed. Just shows you that the thyroid has a great spare capacity. And if we look at the natural history, slow evolution, slowly the patient starting from the thyroid state slipping into hypothyroidism. There's a variant of this that we call silent thyroiditis. It's called silent because it is painless, where there is a three-phase response. There is an early thyrotoxic phase, followed by hypothyroidism, and then restoration of normal function. And to understand thyroiditis, you really need to go back to the basics of the anatomy and physiology of the thyroid gland. So this is a section for the thyroid. The pink stuff is colloid, which is rich in thyroid hormones. The thyroid is very peculiar. It's the only endocrine gland that has a huge extracellular store of thyroid hormones. And these pink spaces are lined by thyroid epithelial cells. So the colloid is stuffed full of thyroid hormones, and in silent thyroiditis, what happens? The autoimmune attack makes the thyroid epithelium leaky, and all these thyroid hormones get out into the circulation and cause the thyrotoxic phase. Now, the thyroid epithelial cells are not destroyed, not at least in this phase, but they take a bit of time to recover, and for some time they're not able to function. So after the thyrotoxic phase, there is a transient phase of hypothyroidism. And then there's Graves' disease, where the underlying problem is the production of antibodies that bind and stimulate the TSH receptor in thyrocytes. This switches on the production and release of thyroid hormones and leads to hyperthyroidism. And typically, the natural history of Graves' disease is that of relapses and remissions. Eventually, usually the patient goes into a constant state of hyperthyroidism. And there is a variant, thyroid eye disease, which we think, again, the pathogenesis is related to TSH receptor antibodies that bind to epitopes in the retroocular space and cause inflammation. And then there's a condition that is referred to as hashitoxicosis. And the first case, and the name hashitoxicosis was invented by Professor Petros. This was a patient who had typical Graves' disease, high uptake on his thyroid scan and positive TRABs, but histologically the gland had the typical features of Hashimoto's, and the patient then became spontaneously hypothyroid. And if you look at the literature, there are two different descriptions of hashitoxicosis. The first one usually refers to children and young adults, where there are long phases of thyrotoxicosis followed by hypothyroidism. And this looks as though it is a thyroiditis predominantly, but it's not very clear-cut. The investigations are grey. So the ultrasound may look like Hashimoto's, but there is uptake on the thyroid scan. And then the other variant of hashitoxicosis, which is commoner, is really down to two different types of TSH receptor antibodies. In addition to the stimulatory ones that cause hypothyroidism, such patients can also have blocking antibodies that block the TSH receptor. And it's the balance between these two that determines which way the patient swings between hyper and hypothyroidism. So then kind of natural history is again swings between hyper and hypothyroidism. I don't like the term hashitoxicosis. the major professional organizations don't use it. It is confusing, and I think it is best avoided. If we look at the pathogenesis of autoimmunity, well, you will have read this in your textbooks, combination of genetic predisposition and environment, and unfortunately we don't really know very much about this. But there seems to be a trigger that leads to breakdown of self-tolerance, and that becomes the onset of autoimmune thyroid disease. So if we think about the immune response in general, there are two types of lymphocytes that are key. Regulatory T lymphocytes suppress the immune response, whereas Th17 cells enhance it. And immune tolerance is a situation where autoreactive T and B cells exist in our body, but they're kept under check. And they're suppressed by T regulator cells. So all of us have autoreactive lymphocytes, but we don't get autoimmune diseases because they're kept under control. And these are kind of like slumbering little angels that do no harm. But then something happens, the trigger, it could be a viral infection, it could be some other traumatic event, and the suppression is removed, and these turn into right monsters. So in Hashimoto's disease, the pathway involves cytotoxic T cells that recognize thyrocytes and cause destruction. There is some evidence that B cells are also involved through production of antibodies to TPO and thyroglobulin. Some of these can be complement fixing and can cause damage to thyrocytes, but this is a minor component. Most of Hashimoto's disease, the destruction is mediated through cytotoxic T cells. And in Graves' disease, it is B cells that are allowed to produce TSH receptor antibodies that lead to hyperthyroidism. In thyroid eye disease, again, TSH receptor antibodies are key, and they can recognize epitopes on fibroblasts and adipocytes in the orbit. And in the last 10 years or so, it's also become apparent that another key component to mediating the effects of TSH receptor antibodies in the orbit is crosstalk between the TSH receptor and the insulin-like growth factor 1 receptor. And indeed, one of the recent therapies introduced in thyroid eye disease is a blocker of the IGF-1 receptor. Now, what I've shown you is still a huge oversimplification of quite complex processes. We also know that besides the lymphocytes and the antibodies, cytokines are important, released locally, and the fibroblasts and endothelial cells in the thyroid and the orbit are not just innocent bystanders, they take part in the immune response. So I'd now like to share some kind of clinical experiences which may be of some value that relate to thyroid autoimmunity. And the first lesson I'd like to go into relates to Graves' disease. And here is an example. So this is someone who, typical Graves patient, female, 45, no extrathyroidal manifestations, and I think most of us would treat such patients with antithyroid drugs for a period of time, 1 to 2 years usually. And unfortunately, this patient relapsed after a year, as happens with about 50% of cases. And when we're faced with this, the usual options are radioiodine, or thyroidectomy, or more antithyroid drugs. And certainly in the UK over the years, the radioiodine was the preferred option after a relapse. But there is now experience and documented outcomes in patients in this situation that are treated long-term with antithyroid drugs after they've relapsed. And by long-term, I mean for years, for decades. And so this is a study comparing the outcomes of this approach compared to giving radioactive iodine to such patients. The results are really interesting and I think compelling because on every account, long-term antithyroid drug treatment seems to be better than radioactive iodine. So better control of biochemistry, better quality of life, lower risk of thyroid eye disease, less weight gain, safe and a similar cost. Now, safety is important, and of course, you would only give long-term antithyroid drugs to patients who have tolerated antithyroid drugs well, and they are reliable in taking the medication, and they're aware of the potential side effects, particularly the need to check for blood count if they get any symptoms of infection. Now, of course, as you know, the risk of granulocytosis is greatest in the first few months of treatment and then declines, but it can happen any time. So if you go for long-term antithyroid drug treatment, your patients really need to be well educated about what to do if they develop such symptoms. So the evidence suggests that long-term treatment in patients with relapsed Graves' disease is a good option in patients that tolerate the tablets and are reliable in taking them. So lesson number 2 it relates to Hashimoto's disease. And if you look at the trend across time on the incidence of hypothyroidism, there's a slow increase over the years. But if we look at the use of levothyroxine, the prescriptions for levothyroxine, this has also gone up, but much more steeply than the incidence of hypothyroidism. And unfortunately, we're in a situation now that quite a significant proportion of people on levothyroxine never had hypothyroidism in the first place. And the majority of those, of the remaining, actually are treated with levothyroxine for subclinical hypothyroidism. And that's what I would like to focus, subclinical hypothyroidism, because in most of these cases, the treatment with levothyroxine is given because patients are reporting and experiencing symptoms. And there's an important paper that was published 4 years ago, which was a large population study looking at patients with subclinical hypothyroidism, not on any treatment, and comparing the symptoms, quality of life, cognitive performance with the background population. And what was found was that these people with subclinical hypothyroidism did not have any more symptoms than the background population. And the accompanying editorial to this paper made this interesting comment: don't react to symptoms in patients with clinical hypothyroidism. So I think what this piece of evidence tells us is that if you treat such patients with levothyroxine, it is unlikely that the patient will actually feel better at the end of it. And if you give them the impression that the treatment will make them better, then you run the risk of raising patients' expectations and then patient being dissatisfied with your intervention. So I'm not telling you don't treat subclinical hypothyroidism. There may be many other reasons why that may be an important and sensible thing to do. But one needs to really manage patient expectations when we do so, because the evidence strongly suggests that in this situation, symptoms don't get any better. So lesson number 3 is about the long-term management of hypothyroidism. And what has become apparent over the last few years is that patients on levothyroxine have the best long-term outcomes if the serum TSH is kept within the normal reference range. Now, this may seem obvious, but this piece of information is really important because meeting the hitting the normal reference range in medicine is not always associated with the best outcomes. But you can see clearly here the pattern that emerges is that patients with raised TSH or a low TSH are exposed to increased risks of cardiovascular morbidity and mortality. And the curve is much steeper patients who have a low or suppressed TSH. So at present, and this may change, the best biomarker of euthyroidism in people being treated with levothyroxine is the serum TSH. And the evidence, I think, strongly suggests that we should be doing everything to keep the serum TSH in the normal reference range. The question is, how successful are we? And if you look at various studies that have been performed in this respect, overtreatment is common between 27 and 41% of people with levothyroxine, and undertreatment equally between 37 and 57%. And this is also another interesting study. If you think about the kind of average patient with hypothyroidism, they are established on levothyroxine, and they usually come to a clinic once a year, and we do the TSH. So here's an example of a patient who hits the, is in the normal range. And normally what we do, we would pat this person on the back and give it another year or two for the next repeat thyroid function tests. But this study from the Netherlands has done something a little different. So they actually brought these patients back within 6 weeks of having a documented normal TSH. And what they found was that between 19 and 24% of patients, depending on the dose of levothyroxine, within 6 weeks had drifted outside the normal reference range. And based on data like this, it can be estimated that 18 million people in Europe and as many as 200 million people globally are at risk of the long-term complications of dysthyroidism, and that is premature death and other complications. And the irony is that the treatment is one of the cheapest drugs available. And if we look at what our academic colleagues have been focusing on in the last 24 years, numerous publications on the topic of combination treatment in hypothyroidism, and very little on medication adherence, which is the main reason why patients drift outside the normal reference range. So the lesson is that we do have clear biochemical targets, but unfortunately we often fail to achieve them. Now, with regards to the future, most of the studies and information that we have about autoimmune diseases refer to the last few steps in the process between breakdown of immune tolerance and the manifestations of autoimmune diseases. And the recent efforts have really focused on the early stages of this process. And one such example is the microbiome, which may turn out to be really important, but it's still early days. And there are a number of other strategies shown here in autoimmune diseases, and I think some of the progress in other autoimmune diseases will be translated to helpful strategies for thyroid autoimmune problems. So the key messages are we should expect major breakthroughs in the treatment of autoimmune thyroid disease in the next few years. In relapsed Graves' disease, I think long-term antithyroid drugs is a very decent option. The importance of managing patient expectations when you treat subclinical hypothyroidism have been outlined. And finally, let's do our best to keep the serum TSH normal in people treated for hypothyroidism. Thank you very much for your attention.